Hi, let's look at another radiology case, shall we? So, we have an 18-month-old neonate who's been presenting with cough for several days, as well as increased temperature, as well as increased dyspnea. So it's a respiratory case, right? So let's look at the chest x-ray that was ordered. So the chest x-ray that was ordered right here. Here we can see in this neonate, there's an abnormality. So pause the video, let me know the finding and the diagnosis, then you can resume. All right, let's continue now. So the abnormal finding that can be seen here obviously is within the right upper lobe, there's an area of ossification. There's an area of an ossification that is seen within the right upper lobe. Now, when there is an ossification on a chest x-ray, remember, the lung is mainly composed of, or the lung's interstitium is mainly composed of pulmonary blood vessels, which are these whitish structures that are branching out. And they're also composed of air. And what structures contain the air? Your alveoli, your bronchioles, which are invisible. In fact, the only structures that are not invisible, which can be seen here barely, are the bronchi, the primary bronchi, the right and the left one, in which the trachea at the level of the carina branch out in the middle. So again, the lung interstitium is composed of air with pulmonary blood vessels that are branching out. But here in this case in the right upper lobe, there's an area of ossification. Now, whenever there's an area of ossification, we don't want to say that's immediately consolidation. No, it could be lung collapse. And I'm not referring to pneumothorax. No, I'm referring to atelectasis, which is meant by, in Latin terms, lung collapse. Yes, there's a difference between pneumothorax, which is also characterized by lung collapse, and there's a difference between that and atelectasis, which is also meant by lung collapse. Now, in the case of this chest x-ray specifically, there's an area of ossification that suggests collapse of the right upper lobe or right upper lobe atelectasis. Now, before I go into details as to how we can figure out whether this is consolidation or this is atelectasis, and if this is atelectasis, how do I differentiate this from a pneumothorax? Because this one is also referred to as lung collapse. Before I go to the details, let me show you the difference between a normal image and an abnormal image. So this is a case of an abnormal image. And in this abnormal image, besides the ossification, everything is normal, all right? Almost everything is normal. I'll show you the abnormal findings. Now, look at this image and compare it to this image, all right? Here, there's an abnormality, this portion right here, but forget about it. I just want you to look at the right upper lobe. Compare the interstitium of the lung of the right upper lobe and compare it to this side. You can see there's a clear difference, right? Now, let's look at some of the other differences that we can see here as well. Now, typically, when you look at a chest imaging, you want to go systematic. So I'm going to look at the diaphragm. Now, if I start here at the level of the diaphragm, the right and the left one, I'll see there's a difference. You see the costophonic angle? They're intact. They're fairly sharply angulated. But if I look at the right hemidiaphragm, the shape of it, the contour, I can see a portion of it right here. It's being dragged upwards. You know, as if someone is dragging the hemidiaphragm upwards towards the region of the ossification. Now compare this finding to the other image that was normal. Look at this. It's not present here. The shape, it's smooth, it's symmetrical. But here, it's as if there's a portion of it that's being dragged upwards. That's important to know. If I look at the left hemidiaphragm, it is normal. The left costophonic angle is also normal. And typically, the right is higher than the left. All right? Usually. Tamam? Now, what else do I find here? Well, I'm going to go up. Now I'm going to look at the ribs. I'm going to look at the chest wall, right? I'm going to look at the posterior ribs and the anterior ribs. And I'm going to look at the chest wall overall towards this region and the shoulder and the clavicle. And then I'll go towards this side. I'm going to look at it again. And to summarize, they are normal, but I'm just going systematic. I'm looking at the clavicle. I'm looking at the shoulder. I'm going downwards this time, all right? Looking at the ribs. There's no abnormality that can be seen here in the ribs, by the way. Now I want to look at the mediastinum, all right? If I look at the mediastinum, the structures in the middle, I can tell you right now that there's an abnormality. That abnormality being the trachea. Now, the trachea is in the middle. It's a lucent tube structure. It's a tube composed of air. So it's going to be seen in the middle as a tube lucent structure. Now the trachea, if you can notice it somewhat, is being deviated towards the right. Is being deviated towards the ossification. So now we have two structures that are being dragged towards the area of ossification. You have the right hemidiaphragm and you have the trachea. They're both being deviated towards the area of ossification as well. And if I look at the heart, for instance, the heart, it's not deviated, it's normal as it is. So we have the left ventricle, you have the right atrium. It's not deviated towards any other region. It's completely intact. But we can comment that the trachea is being deviated towards this region of ossification, this trachea right here, as well as the right hemidiaphragm. And we can see a positive sign that is commonly seen in X-ray. It's not exclusive, it's a general sign. That sign being the ciliate sign. So in this region right here, on the right tracheal border, as it divides at the level of the carina, here we have the ascending aorta. The ascending aorta that's making up the left border of the heart. The upper side, The ascending aorta, I'm not seeing its shape. This shape right here, like if I show you, I'm not seeing the ascending aorta. The ascending aorta that gives the shape of the left border of the heart towards this region, right? Because this is the right atrium giving the right border of the heart, the right border of the heart, the lower portion, while the upper portion of the right side of the heart is the ascending aorta, giving us this shape. But this shape here, I'm not seeing it. It's obliterated. This is known as a ciliate sign. Whenever we see a loss of a border of one structure because it's interacting with another structure within the same density, being soft tissue density, being gray density, this is known as a ciliate sign. Look at the difference between this one and this one. Here I'm not seeing the ascending aorta. The borders of the ascending aorta is not seen because the ascending aorta, its density is gray. It's soft tissue. And it's interacting with another soft tissue density. That being this ossified mass, this ossified region within the right upper lobe. This is known as a ciliate sign. So there are a number of abnormal findings that can be seen here. We said first, the right hemidiaphragm is being dragged towards this region. We said the trachea is deviated towards the right, towards this region as well. And we said that there's a positive ciliate sign as well of the ascending aorta. And the ciliate sign is important, by the way, because it localizes the disease. It localizes the problem. Is it anterior? Is it in the middle? Is it in the posterior? Because the problem with X-rays is that the structures are overlapping. It's not like CT. So we rely on signs like a ciliate sign. That's the purpose of it. So these are the abnormal findings that we can accumulate. Now I finished with the mediastinum. There's nothing abnormal. The hilum, the pulmonary vessels, they're all normal. Now we finally come to the lungs itself. I'm coming to the lungs itself, the air fields, the black fields. So I'm going to start with the right side. The lower zone, the middle zone, I'm talking about the middle and the lower lobes of the right side, they're intact. But as I go up, I finally comment on the obvious, and that is there's an area of ossification in the right upper lobe. All right? Now, if we notice in this area of ossification, there's no presence of an air bronchogram, which means presence of bronchioles within the area of ossification. If you recall, bronchioles are invisible. They're composed of air. But if we see the bronchioles within a consolidated mass or within an ossified mass, then we will see them visible. This is known as air bronchogram sign. But here it's absent. So it tells you that lobar pneumonia is not likely the case, especially in an 18-month-old neonate. And besides absence of an air bronchogram in this ossified region, we can see that the borders of it are very sharp. They're very sharp. And that's important because this sharp border right here that is abutting or that is adjacent to the ossified mass, this sharp border, it represents the horizontal fissure. Yes, the minor fissure that is present within the right lung in order to give you the upper lobe, the middle lobe, and the lower lobe. So the minor fissure that is present in the frontal X-ray, it is usually in this region, but now it's dragged upwards. It has been dragged upwards, and now it's presented as a very sharp border of the ossified region within the right upper lobe. All right? So these are all the abnormal findings that we can see here. Meanwhile, on the left side, it's normal. The left side for the lung fields, they're all normal. This is a pulmonary blood vessel, all right? From the hilum and it spreads out. That's normal. So let's again summarize the abnormal finding. This is a frontal X-ray of a neonate presenting to you with respiratory symptoms. If I look at this X-ray, I see that there's a presence of ossification. There's a region of ossification in the right upper lobe, and this is more than likely to be right upper lobe atelectasis as for the cause of ossification, not consolidation, not pneumonia. Why? Because there are structures that are being dragged towards it. The right hemidiaphragm dragged towards it, the trachea dragged towards it, the ascending aorta, ciliate sign. Also, we're not seeing it present here. Also, the minor fissure dragged towards it, and absence of an air bronchogram sign. So all of these together tell you that there's an area of ossification. This indicates that this ossification is specifically right upper lobe atelectasis or right upper lobe collapse. Now, to finish off the video and tell you the case presentation, obviously, as you can see here, right upper lobe atelectasis. Here it's telling you in the case presentation, the cause of right upper lobe collapse for this baby was due to bronchiolitis. Now, before we end the video, let me teach you the concept. Let me tell you the difference between an atelectasis and pneumothorax, because both of them mean lung collapse. So let's open up MS Paint, shall we? So I'm going to open up MS Paint. All right, here we go. Let's open up MS Paint, shall we? Now, let me show you the difference. So, here we have a case of a normal lung, right? Here we have a normal lung, and let's say this is the right lung, all right? This is the right portion of the lung. Now, as you know, the right lung is divided into 3 lobes: the upper lobe, the middle lobe, and the lower lobe. And what divides the lung into 3 lobes? The fissures. And where did the fissures come from? From the visceral pleura. They overlap over one another and they give you the fissures. And as you know, the fissures, they appear on X-ray as a thin white line. All right, they appear as a very thin white line, like in this portion right here. So here we have the minor fissure, the horizontal fissure, the same meaning. And here we have the oblique fissure as well. The minor fissure, it gives you the middle lobe. The oblique fissure, which is also present on the left lung, they give you the upper and the lower lobe. All right. So on a frontal X-ray, we will see the lung's interstitium. It is composed of air. And what structures contain the air? Alveoli and bronchioles, which are invisible. And surrounding the alveoli and the bronchioles are pulmonary blood vessels, are surrounding the fissures. All right. So you have the pulmonary blood vessels that are branching out, and you also have the fissures, which are separating the lobes, respectively. So this is a right lung that is normal. All right. Now, let us say, for example, in a case of bronchiolitis, typically in neonates, they are prone to a respiratory infection, not asthma, not pneumonia, bronchiolitis. And what is meant by bronchiolitis? It is meant by inflammation of the bronchioles. So let's say, for example, this tube here, by the way, it is a bronchiole. Now let's say with inflammation comes fluid, right? Comes mucus plug. And let's say I draw a mucus plug here. All right, let's say I draw one right here. All right. Normally a bronchiole, as we said, it is composed of air. It goes towards the alveoli and then it comes back out of the alveoli, like a normal tube, right? But let's say there's a block in this tunnel. There's a block in this bronchiole. There's accumulation of fluid here, a mucus plug that arises from the inflammation. And now this mucus plug, this white structure, it is obstructing the air. Now the air that is going towards this region is not going towards this region. And now the air that's being absorbed towards this region is not being absorbed towards this region. So we have a mucus plug here that is obstructing in the way. It's getting in the way. Air cannot be absorbed. Air cannot go through. So because of this mucus plug, now any air, by the way, any air that's being absorbed distal to this mucus plug, is being absorbed. It's going towards this region. All right. And what that happens, what is the end result? What is the end result when we have air that's being absorbed distal to the obstruction, this obstruction specifically? Now the lung, this portion of the lung, this one right here, all right, this portion of the lung, this one will collapse. Now this portion of the lung, it will collapse because there is no air that is coming towards it. Any air that's coming towards it is being obstructed. It's being blocked because of this mucus plug. So now we're going to have a region of lung collapse in this region. So what is the end result? What is the end result? It is right in front of you. This portion right here. You see this lung, you see this arrow? This arrow will show you the end result. So here we have a case of an obstructive atelectasis. So let's say specifically in a case of bronchiolitis, let's say here, let's say in this region right here, let's say we have a obstruction. So this bronchiole is in the right upper lobe, all right? We have an obstruction. There's no air being absorbed. Now it's practically being collapsed, and now this right upper lobe, instead of looking like this, is now looking like this. So this is what the right upper lobe is going to look like. Look at the difference. First, number one, the size. You see the right upper lobe, it was big. Now it's getting smaller in size. There's loss of volume. Loss of volume specifically of air. So loss of air means loss of volume, all right? So it's going to be loss of volume or loss of the size of the right upper lobe or loss of the size of the right lung in general, all right? That's number one. Number two, notice the density. Here it was black, but now it's white. Why is it white? Because there's no air. Remember, the mucus plug is on the way. So there's just no air coming towards the right upper lobe or coming towards the bronchiole of the right upper lobe. So now it's going to become white. White indicating absence of air. So remember, when there is opacification, it can mean two things. It can mean fluid or it can mean collapse. Regardless, what do these two have in common? Absence of air. So there is absence of air because if there is a collapse. There is no air being absorbed. All right, that's number two. Number three, and the final thing, look at the borders. If you notice, the borders is triangular in shape. These borders represent the minor fissure. So we can see the minor fissure, it's dragged towards this region. So any structure near the right upper lobe, the minor fissure, the trachea, the right hemidiaphragm, they'll be dragged towards it like a black hole. So it's like a black hole. It will drag whatever structure surrounding it. And why does it drag all these structures surrounding it? You might ask yourself, why is it dragging all these structures? Because whenever you have a lung collapse like this, the pleura, the visceral, and the parietal pleura, they're still intact. So what I'm trying to say here is that the visceral and the parietal pleura, they are intact. They're not separated. They're both intact, and they're being collapsed along with it. So here in a case of a right upper lobe, we have the visceral and the parietal pleura. They're being collapsed along with it. And if the pleura and the lung both together are collapsed, they will drag all the structures towards it like a black hole. And this is the biggest difference between obstructive atelectasis of a right upper lobe and pneumothorax. In pneumothorax, the pleura, the visceral and the parietal pleura, they're being separated. So there will be no structures that are being dragged towards it. It's the visceral that's being separated from the parietal due to air, due to fluid like pleural effusion. But in the case of atelectasis, everything, including the pleura, the visceral, and the parietal together, they're being collapsed. So all the structures are going to be dragged towards it. So these are the key differences. So in a case of obstructive atelectasis, you have the size. There's going to be loss of volume. That's number one. Number two, opacification with no air bronchogram. Everything is collapsed. And number three, there will be dragging of structures. Structures will be dragged towards it, and that is because the pleura is a part of it. All right. So this is known as obstructive atelectasis. There will be sharp borders from the fissures, and there will be structures dragged towards it. All right. That's pretty much it for the MS Paint. All right, and that's pretty much it for the case presentation. All right, now you know the difference.